Thank you, Maura. Thank you for the invitation to speak today. So I have no disclosures. So why are we talking about the transmission of oral HPV? First, I'll talk about how this is clinically relevant to us as head and neck surgeons, oncologists, and radiation oncologists. I'll also discuss some of the data that we have to date, which is limited, and then the implications of this for counseling. So HPV is strongly associated with diagnosis of oropharyngeal cancer. We know that presence of oral HPV-16 infection is strongly associated with diagnosis of oropharyngeal cancer when we compare patients with diagnosis and controls. We also know that the presence of antibodies to E6 or E7 oncoproteins is strongly associated with the diagnosis of cancer. We also know that the presence of antibodies precedes the diagnosis of cancer by at least 10 years. Maura and Anil up here have very elegantly demonstrated that oral HPV infection increases with increased number of lifetime sexual partners in a dose-response fashion. We also know that sexual behaviors are associated with the diagnosis of HPV-associated oropharyngeal cancer. Increasing number of lifetime oral and vaginal sexual partners associated with diagnosis, having participated in casual sex, infrequent use of barriers during either oral or vaginal sex is associated with oropharyngeal cancer, and the history of a sexually transmitted infection such as herpes simplex 2, as well as early sexual debut. Just as with sexual behaviors and oral HPV infection, increased exposure increases the risk of diagnosis in a dose-response fashion. So if you see oral sex in the fourth panel, I don't think I have a pointer, fourth panel over, increases dose-response fashion. We also know that partners, husbands of patients with cervical cancer have a twofold increased risk of diagnosis of oropharyngeal cancer. So that's why this question comes up clinically. We know that oral HPV infection as well as HPV-associated oropharyngeal cancer are sexually transmitted, and that this risk increases with increased exposure as measured by lifetime number of partners. From the anogenital literature, we know that HPV is concordant among partners. It depends on how this is measured, sample size of the study, as well as the frequency of sampling. But when you look at HPV type concordance among partners, it ranges between 28% and 68%. So in smaller studies of oropharyngeal cancer patients, they also express concern regarding transmission. In a study from Memorial Sloan Kettering, which was a descriptive study interviewing 10 patients, 5 out of 8 expressed that they had decreased their intimacy due to fears of transmission. This was also related to treatment side effects, but they did express concerns of transmission. For example, patients said that it was in the forefront of their mind, why would they do it again to themselves? Another patient said he'd been burned on the stove before, so even though it was off, he was still a little scared of the stove. So patients were interviewed in that study, but their partners were not interviewed regarding their concerns of transmission. So when we think about transmission, it's actually fairly complicated. It differs by gender, so transmission from female to male versus male to female. In terms of heterosexual couples, is different. We have to consider viral and host factors, exposure, susceptibility, and the different factors that make one more susceptible to infection, the probability of transmission, duration of infection, and the frequency of sampling. So for anogenital infection, we have a pretty good understanding of these dynamics. However, in oral HPV, we don't have a very good understanding of it because natural history studies are pretty limited. So in the meantime, to answer this question of transmission, Dr. D'Souza was the PI of a study at Hopkins as well as other institutions including Dana-Farber and Mount Sinai Oregon Health Sciences to determine whether or not oral HPV infection is elevated among partners of patients with oropharyngeal cancer that's HPV positive. Patients who had HPV-associated oropharyngeal cancer and their spouses of at least 2 years were enrolled, as well as healthy controls. They looked at E6 and E7 sero antibodies, as well as HPV status in oral rinses. The partners all had oral exams to screen for cancers. So the patients with HPV-associated oropharyngeal cancers, whether or not they had a partner enrolled with them at the time of the study, were fairly similar. But what you note is that the partners were different than the patients in terms of gender distribution. Most of the partners were females, and they did differ in terms of their sexual characteristics, with partners having fewer lifetime number of oral sex partners and older age of sexual debut. But when you looked at the presence of oral HPV infection among partners and patients, what you see most notably is that none of the partners had an HPV-16 infection present. And then when you compare it to NHANES data from 2009 and 2010, which Anil and Maura generated, you see that this is similar to the United States population in that HPV-16 is rare. And then when you look at it among women and men, similarly, partners had similar prevalence of HPV infection for both genders. And then when you look at the cancer history among partners, most partners had no history of HPV-associated cancers, and none had any evidence of a present malignancy when they were examined. One partner had a prior husband with oropharyngeal cancer. So the history of an HPV-associated cancer in partners was actually pretty rare. And then when they looked at serum, so the presence of E6 or E7 antibodies, they were associated with diagnosis of cancer, but then when you compare partners and controls, they were actually similar. 0% of partners had the presence of an E6 antibody, and 0% of partners were seropositive to E7. And this is similar to controls. So what about after treatment? In this study, when they looked at the presence of oral HPV-16 infection after treatment, while 53% had been positive at diagnosis, only 4% had an infection 1 year later. So oral HPV was undetectable in most of these patients 1 year after therapy. But you have to put that in context in other studies. So this study, which Dr. Gillison did back in 2008, looked at HPV of all types among HPV positive and HPV negative patients. The top of the panel is, actually here's a pointer. The top panel is HPV positive patients, and the dark lines are patients who have HPV present in their oral rinse and their various types. And this is over time after therapy. And what you see is that at time points greater than 1 year, there are still patients who are HPV positive in their rinses. So despite this evidence, you still hear from patients' spouses, but I've still been exposed. So we have to come back to this argument that we tell them that very few people actually get the infection, and then even fewer go on to get the cancer, despite most people being exposed at some point. So this comes to the concept of absolute risk, which if you think about the number of people who are exposed and the magnitude of risk of people developing disease, that's expressed by absolute risk. So we can ignore the people who are not exposed and just look at the number of people who are exposed and the ones that go on to develop disease. So If you look at the US population, sexual behaviors are common. So all these proportions for each of these behaviors in the 2009-2010 NHANES data is over 80% for each of these behaviors. Yet the prevalence of HPV-16 infection, as well as other oncogenic types, is less than 1%. And most infections from the limited natural history study we have clear. So most of them clear within a year. Oops. Most of them clear within a year, and then all of them have cleared by 18 months. So if we think about natural history of oral HPV infection, most infections are kind of in this circle over here. They're incident, they get cleared, or if they persist, they're going to go back and clear. And we think some may get reactivated, become latent and get reactivated. Very few go on to develop oropharyngeal carcinoma. And then the other thing to think about is that while we're seeing these epidemiologic changes in terms of HPV-associated cancers, with a significant rise in HPV-associated cancers over time, and a reduction in cervical cancer, we're not necessarily seeing that among partners, at least as far as we know. It hasn't been reported. So what can patients tell their partners? They've been exposed. These behaviors associated with oral HPV are very common, since we're all human beings. Exposure is not equivalent to cancer. Patients can consider protection with new partners, and their partners should follow cervical screening guidelines, as it is they've been exposed to HPV. And in the cervical cancer and cervical HPV counseling literature, there is discussion of whether or not patients have to tell their partners. And based on cervical HPV literature, there's no obligation to tell partners about the presence or absence of HPV. So in conclusion, oral HPV is rare. Oral HPV and HPV oropharyngeal cancer are rare among partners. Female partners should follow cervical screening guidelines, and natural history studies will further elucidate the factors involved in transmission. Thank you. And then
so, Carol, are there any questions from the audience for Carol? I just wondered, Carol, occasionally in my clinic, I'll tell the spouse all the things that you recommended, and they still can't sleep at night. So, as a ENT, do you ever actually recommend that they undergo oral cancer screening in any way? Because there's an occasional patient who just can't sleep at night, and their spouse can't sleep at night.
Yeah. So I don't necessarily recommend it because, you know, it's not as though we can, there are guidelines for oropharyngeal screening, I should say. There's occasional patients who will just do it because, or spouses will do it just because it'll make them feel better. But we don't have at present any guidelines or any screening recommendations for partners.
Okay, thank you. And Carol has up on the screen now, you can download it from the internet from Oral Oncology, I believe, a pamphlet that you can have available in your office to hand out to your patients for addressing these questions.